We'd like to go ahead and get started. Welcome and thank you for so many of you coming today. I know you're going to find this most interesting. It's just my privilege to introduce Dr. Ben Stultz. And Ben and Jessica and their girls are members of Redeemer. But Ben works in critical care at Mayo. And in doing that, and he has other experience as well, but in doing that, he has daily conversations, obviously with patients and families about end-of-life decisions. And so this is a passion of his, and I've heard him give it previously, and it's just wonderful. Please don't hesitate to ask questions, but we ask you to speak very loudly because we're taping this to put on the website for people. And Ben said he can speak loudly too, although he's got a pretty soft voice. So with that, please help me welcome Ben Stultz.
Oh, thank you. So I'm Ben. If at any point you can't hear me in the back, please tell me, and I can absolutely be louder. Louder? Okay, sounds good. We can just start up a little bit of volume. So we'll be talking today about a great topic for the first Sunday of Lent, just to bring us out on a real high note, for end-of-life care and decision-making. Goals today will be, first and foremost, to answer questions about end-of-life decisions. Secondly, to give some understanding of advanced directives. Third, and maybe most importantly, identifying how to choose a medical decision maker for yourself. Deciding what matters most in your life, and then discussing communication with decision makers. We'll see if we can accomplish all of that. So about me, I grew up in the Twin Cities, not too far away. You may have seen me and my wife and our two girls usually sitting in the back of the sanctuary because the two girls like to run around whenever possible. She and I met in 7th grade. I've been married since 2015. Our two daughters are currently 5 and 2, going on like 17 and 15. And when I'm not doing things like this, I like being outside, camping, hiking, working on many house projects, biking, and mostly drinking lots and lots of coffee. Some background. I went to undergrad in the Twin Cities at Bethel, where I studied chemistry and molecular biology, did my medical school at the Medical College of Wisconsin, and then I've been at Mayo since 2020, where I completed my residency in internal medicine, which is a complex adult care, caring for adults inside and outside of the hospital. Thankfully, I don't think any of you were on my primary care panel, but I've been in a couple different things there. I took an extra year as a chief, where I was supervising 180 residents, and I worked as a consultant, mostly inside the hospital, and I'm now in my fellowship, working in critical care, where, for better or worse, I very frequently talk with patients and families about end-of-life decisions. One of my main goals is that if you or your loved ones have to meet someone like me inside of the hospital, that a lot of things have been pressed beforehand, so you have some framework for how to approach difficult decisions. A little bit more about me, and maybe more importantly, who I am not. I am a doctor. I am not your doctor. I don't know your complexities or your life. I am not a pastor. I do see at least a pastor in the room, so we can defer to them for some extra questions. I am not your decision maker, and I don't know your story or what's best for you. Hopefully, we'll have plenty of time for questions, and there's a number of people in the audience who I may lean on to help with any particulars that you guys ask. So the roadmap for today will be, first of all, to talk about some terms and definitions, and then secondly, to talk about a framework for decision-making and surrogates. So first, for terms, I have a few pages of these, unfortunately, but there's some helpful things for us to be able to use the same kind of language with. The first one is an advanced directive. I'll briefly call this, because I'm sure that Justin could come up with a longer definition, a legal document outlining your medical care preferences if you can't communicate them. Generally, this includes pretty broad information. I don't want to be on a ventilator for years. Good. Most of us don't. One of the difficulties here is because they tend to be pretty broad, when it comes down to the nitty-gritty of day-to-day decision-making, it can be hard to interpret What would you and would you not want? A living will is generally a type of advance directive, I'll call it, that specifies the medical treatments that you do or do not want at the end of life. I never want dialysis. I never want to be on a ventilator. Some of these kind of slightly more specific things. A power of attorney for healthcare is a legal document allowing someone you trust to make medical decisions for you if you are unable to. We'll talk some more about choosing surrogate decision makers for yourself. That's my main legal definitions page, Justin. Anything you would change there or add?
I like that a lot.
Okay, sounds good. Then a few nitty-gritties inside the hospital. A really important one is DNR and code status. So DNR stands for do not resuscitate. If someone ever asks you about your code status, that's us asking what you want to do if your heart stops, if you stop breathing, if you die inside the hospital. How do you want us to respond? So DNR, do not resuscitate, means no CPR if your heart stops. Code status indicates your preferred level of emergency care, being full code, where we would run in the room, put in a breathing tube, press on your chest, probably break some ribs, shock you to try to restart your heart. A really important caveat I want to put here is that your code status, your DNR status, has no bearing on your other cares. If you meet me in the hospital and I ask you, if your heart stops, do you want us to run here and press on your chest, probably break your ribs, shock your heart to try to restart it? That doesn't impact any other decisions we're going to make. If you have an infection and you say, I don't want to be full code, I'd like to be DNR, I'm going to give you antibiotics. If your blood pressure gets low, I'm going to give you medications to raise your blood pressure. If your kidneys fail and you want dialysis, we'll do dialysis. This is really specifically a question that I'll sometimes word as, if you die while you're in the hospital, do you want us to try to restart your heart? Comfort care is medical care aimed at keeping you comfortable and relieving symptoms, not curing the illness. This is something that will frequently overlap with illness-directed cares. If you have cancer, we're giving you chemotherapy. We'll also be giving you pain medications to try to help keep you comfortable. And over the course of an illness, where that aim is can shift for how much we're aiming at trying to reverse a disease process, or have we realized that we can't really impact this disease process and we're focusing more exclusively on comfort-focused cares. Palliative care is medical care focused on relieving symptoms and the stress of serious illness to improve quality of life. This also exists on a spectrum and can be something that's happening while you're receiving really intense therapy for anything else going on. Especially if you or a loved one are inside the hospital, you may see that we reach out to even a palliative care team to come help us control symptoms while we're treating an infection or treating cancer, or while your loved one is on a ventilator, to help us make sure that we're relieving symptoms, keeping people comfortable. Some people will tie palliative care with hospice, which sometimes is true, but isn't always true. Hospice is a team available when people are nearing the end of life that generally exclusively provides comfort-focused cares. So that's at the point where we've said, this illness is something that we can't reverse, we can't impact. We're not going to be able to prolong life in a meaningful way that this person would want. And then some people will choose to have hospice involved to help perform things like comfort care and palliative care. My last page of terms and definitions, and then we'll pause for questions after I read a whole bunch of things at you. Terminal illness is a disease expected to lead to death. Many people walk around with terminal illnesses for a surprisingly long time, but there are disease processes that we expect to lead to death. Quality of life is someone's overall well-being, including comfort, daily activities, emotional health, social interactions, the things that make you get out of bed in the morning and still go about your business. And goals of care is a lot of what we're going to talk about today, but is your desired outcomes from medical treatment, like relieving pain, maintaining independence, making it to Christmas. People will have sometimes very particular goals. Okay. That's going to be the most reading that I do, hopefully. What questions do you guys have about terms and definitions? Yeah.
So if a disease is incurable but treatable, is that considered a terminal illness?
Generally, yes. So let's say, for example, that someone has a really bad cancer. We may say that this is a terminal illness. We might, with some chemotherapies, be able to prolong life. There will usually be a balance there of we can probably prolong life with some side effects involved. We would still call that a terminal illness, though, because we would call that like palliative chemotherapy is the formal term. We're trying to prolong life with the treatment, but it's still a terminal illness. Not all cancers are terminal. Let's be clear before I keep saying things like that. What other questions do you guys have? Yeah.
I always thought comfort care and palliative care were about the same thing. Can you define what's really the difference?
They're very, very similar. Palliative care, I would say, generally uses comfort care to treat someone. And maybe more of a team than an approach. But you can use those terms almost interchangeably. Yeah. The main thing that I want to draw out by giving those different definitions is to say that palliative is not the same as hospice. Yeah. Yeah.
Can you receive both of those in your home?
Yes, you absolutely can. Yeah, there's some logistics at play with how that occurs, but yeah, absolutely. Most hospice care happens outside of the hospital. Okay. So the framework for the rest of the conversation will be to go through this. This top one is a website. It's prepareforyourcare.org. I highly recommend it, and it's where I stole most of this from. They make it clear on their website you're allowed to steal things from them. If you go to that website after this and you want to actually put things down in writing, it will walk you very, very linearly through each of these steps to be able to spell out what you would and would not want for your loved ones and others if they have to make decisions for you. But the first step there is to choose a decision maker. The second step is to decide what matters most in life. The third step is to choose a level of flexibility for your decision maker. The fourth step is to tell others about your wishes. And the last step is to ask the right questions. And we'll go through each of these in more detail. So step one, choosing a medical decision maker. Why should you do this? The vast majority of you at some point in your life will not be able to make your own medical decisions. Whether that's a temporary thing or a more long-term thing, someone else at some point will most likely have to make decisions for you. Doctors need to know who can make decisions for you. And as opposed to some other states, Minnesota has no defined hierarchy of natural decision makers. So some states say if you can't make a decision, we immediately defer to your spouse, if you have one, to be your decision maker. If you don't, we go to your eldest child. If you don't have an eldest child, we go to your parent, yada yada. Minnesota does not have a law like that. So if you are in a setting where you can't make your own decisions, and I met you for the first time 5 minutes ago, I have no idea who to talk to help make decisions for you. So it's really important that you've thought ahead of time about who you would want to make medical decisions for you. What this is a medical decision maker, is someone who would only make decisions for you if you are unable to make decisions or if you don't want to make decisions. You're not saying ahead of time, I want Bob to make all decisions for me moving forward. You're saying, I want Bob to make decisions for me if I don't want to make the decisions, or more likely if I am unable to make decisions at the time when this is happening.
Hey, Ben.
Yeah.
So what happens if you're out of state and you pass away and you're by yourself? There's nobody there. Who makes decisions at that point?
That gets really, really messy, is the shortest answer. The longer answer is, as a general rule, given the climate that we practice medicine in here in the States, if you are somewhere alone and I don't know anything about you, we will usually keep doing things until we're able to find someone who's able to answer questions for us. We tend to err on the side of being more aggressive with treatments unless we're able to find someone who can tell us this person would not want this.
Isn't that why you put like stuff on your driving license or carry a DNR, DNI card?
That can be helpful. There's some extra caveats about when we do and don't trust things like a card that says DNR, DNI, because of some of the complexities of our legal system. Yeah.
DNI.
Do not intubate. Sorry. Yeah. Do not put on a breathing machine. Okay. So for choosing a medical decision maker, how? First of all, think about who you may trust to make decisions for you. This can be your spouse or a child, any loved one, a neighbor, someone here in this room. Choose a time and place to talk with them, to say that you would like them to make decisions for you. Make sure they understand what you're asking them to do and give them time to think about it. This is a surprisingly important role you're asking someone to serve for you. It's really unfortunate in the hospital when we call someone and say, Joe said that he wants you to make decisions for them, and they say, I didn't know that. And that makes things a little bit more complicated when we're asking someone to make decisions for someone else. An example of language you could use could be to say, my doctor thinks it's important to choose someone to help make medical decisions for me. This is in case I get sick in the future and cannot make my own decisions. If this happens, would you be willing to work with my doctors to help make medical decisions for me? If this, would you be willing to help out? Okay. What questions do you guys have about choosing a medical decision maker? Yeah.
Do our local hospitals, or Mayo,
Yeah.
whoever, if I have a medical directive
Mhm.
on what I want, can they be my decision maker? Rather than choosing somebody for that responsibility that I don't want to have that responsibility.
So that's a really good question. For some things, yes. If it's clearly written out in something like an advance directive or something that you've put on file with a local hospital, then I can defer to that. So-and-so said they would not want chest compressions at the end of life. I'm still really, really going to recommend choosing someone to make decisions for you if you can't, because a lot of the things that are written out ahead of time don't actually provide the day-to-day kind of questions that we're going to be asking. Because complexities come up. Say that you thought that you would, actually I get into this in a couple slides, but say that you thought there was something that you would never want. But, like, let's say that you never want dialysis. There's lots of different things that can lead to dialysis. So usually what people mean is, if they don't want dialysis, they'll say, they're picturing, I don't want to be on dialysis for years at a time. What if I said I could give you dialysis for 3 days, and then your kidneys will probably get better? Would you want dialysis then? And these kind of questions usually aren't spelt out in that kind of a document.
Okay.
And that's where it's really helpful to have someone we can actually talk to. Because if I'm your doctor in the hospital, I don't know you. I don't know what you want or what life is like for you. I see you inside the hospital. Which brings us into, and we'll touch a lot more on that. Sorry. What other questions do people have here on choosing a medical decision maker? Yeah.
You want to repeat the question, Ben?
Oh, yeah. The question there was if...
I meant overall. I don't
yeah.
know if you need to, but
Sounds good.
yeah.
So basically, I know somebody on there that had the wife on there as a caretaker many years ago. Then she developed Alzheimer's. They never updated their thing, and the other person needed a directive. What do they do at that point? Because the other one couldn't make no decisions.
Yeah, so that also gets really messy. If, and we'll run into that, someone attends something like this and they write down, I want so-and-so to make decisions for me, and then it's 10 years later, and that person no longer has the mental facilities to actually make decisions for someone. We do assess them at the time of decision making to see if they are if they have the capacity to make decisions for you. If they don't, then we'll try to find other people. Or it can be helpful to say, I would want this person to make decisions for me. If they're not available, if they're unwilling, I would like this person to make decisions for me. If they're not available or unwilling, I'd like this person. You can go as long as you want to. Hopefully 1 or maybe 2 is enough, but yeah. Yeah.
You should point out how sometimes family members don't agree. So it's important to have
That's really helpful. Yeah, true. If you're blessed by having multiple people in your life who are invested in how you're doing, it can be nice if you have said ahead of time, I want so-and-so to make decisions for me, and they know that, and equally importantly, everyone else knows that. To say, we have had these kind of discussions, I know what mom wants, I know what dad wants. That also can feel like you're picking someone, and that can feel weird. That tends to work out better for families, because what a lot of people don't want is they don't want decisions for them at the end of life to cause strife within their family. So the more clarity you can provide for people, generally the better. Okay. Step 2 is going to be to decide what matters most in life. A easy topic, of course. This is asking what's most important in your life. Your doctors, your decision makers need to know what's most important to you, whether that's family, friends, pets, hobbies, working, independence, watching Sports Center, not being a burden, making it to church, something else. What are the things that are really important to you that you want or need to be able to continue doing? What brings you joy? What are you most looking forward to? Are there tasks that you need to do to make life meaningful? If you can't walk the dog, do you not want to keep going through treatments? Okay, that might be someone's answer. If you can't sit upright on a couch and watch TV, would you not want to go through treatments? Is there something that makes life meaningful for you that may be a line in the sand of what functional status you want to make sure you're able to get back to? With this, considering and deciding what matters most, consider prior experiences you've had with serious illness. Things like that have happened to yourself or your friends, your family, maybe even things you've seen on TV. However, a lot of those tend to be relatively inaccurate. Think about things that went well, things that did not go well, and why. When Dad was really sick, he was in the hospital for the last 3 months of life. I didn't like that. I don't think I would want that. Even those kind of reflections are really, really helpful. And telling someone that can be really beneficial. And my extra caveat here is that quality of life differs for each person and at different times. 2 people are 2 different people and may want different things and have different priorities. On a spectrum between having a main goal of living life as long as possible, no matter what, which is some people's answer and is an acceptable answer, and other people who say my main goal is to focus exclusively on quality of life and being comfortable, which is also some people's answer and a very reasonable answer. At this point in time, where do you lay in that spectrum? That's going to change, but we all exist probably somewhere on that spectrum, and that's helpful to talk to people and think about. So another way, because this is a heavy topic, to approach this is to ask yourself, if you were so sick that you may die soon, what would you prefer? Ranging between trying everything, even if unlikely to survive, trialing life support for a limited time, something like being in the critical care unit or the intensive care unit, focusing on being comfortable and having a natural death, I'm not sure, also a very acceptable answer at this point. If you were at the end of life, where would you want to be? Most people answer, I would like to be at home. A lot of people are not at home. And so that can be something helpful to communicate with people. What else is important? Food, music, pets, people. Do you want to be by your dog? Do you want particular music playing while you're approaching the end of life? Are there people you really want to be present at that time. These are helpful things to think about that you may have thought about before, but maybe you haven't actually told someone, and it's going to be important to tell someone. It's okay and normal to change your mind here. Right now, I'm relatively young, but continuing to age, and I have 2 littles, and my wife, and I'm reasonably healthy. If I get very sick, I'm probably going to have them push lots and lots of things, because my likelihood of recovery is decent, and I would like to continue providing for my family. In a few decades, that's probably going to change. And that may change for you on the order of decades or on the order of weeks. And that is very acceptable and very normal. These are stressful questions. Hopefully going through these types of questions helps you assess future scenarios. None of us can predict what is going to happen to you in the future, what you're going to run into, what kind of illnesses you may have or are going to have. And asking yourself these kinds of questions beforehand can help you and your decision makers navigate uncharted waters. Okay. Questions on deciding what matters most in life? Yeah.
2 years ago, my sister-in-law fell getting out of the tub. She was in her 70s.
Yeah.
Paralyzed from the neck down. Was transferred to St. Mary's and was found to be, within 5 days, nothing, there was no reaction to anything. She would be paralyzed forever. They were ready to, well, she was already intubated, but they were ready to place feeding tubes, and they were looking for replacement. She said, I want to go home, meaning to heaven. She's a Christian.
Yeah.
And on the 8th day, she did just that. Which, to us, it was wonderful, because that's what she got, what she wanted and stuff.
Yeah.
People have told me, they said, that's the same as self-assisted suicide. And I said, I think it was probably a very good, I'm sure she had it written down. We were absolutely in Arizona at the time, so I didn't know it. But I never thought of it that way, because it sounded like that, but we knew her and knew her thoughts. But there was no hope of her ever getting better. All the tests said. And she was her mind was fine, and she was trapped in the body. And she had a long life ahead of her, I'm sure.
Yeah.
So how would you respond to that when people say that?
I really appreciate you bringing that up, because that is a frequent idea that we encounter. And I will now talk specifically from the LCMS perspective. We are not a purely vitalistic denomination. We would not say that stopping treatments is the same as choosing death. I'll reference a couple helpful articles that you guys can read after this if you want to, that come from the LCMS. This is a really, really important point, though. Choosing I don't want treatments is not the same as choosing I want to die. It depends on where you're aiming at. We're going to go a little far into ethics, but there's this concept of double effect, which is saying, if I am choosing that I don't want chemo anymore because of the side effects, because of what is happening, because of the quality that would impact on my life, that choice may lead to my demise. That is not the same as choosing I want to die. That is saying I don't want to experience this. We can approach the same kind of thing with pain medications at the end of life. You can say, I don't want to be in excruciating pain while I am dying. And we will give you medications at the bedside to relieve pain, aimed at providing someone with comfort. Those medications can have side effects. They may make someone sleepy. This hasn't really been borne out, but there's the possibility of them hastening someone's death. That also is not the same thing as choosing death. That is choosing to be comfortable at a time, or to try to achieve comfort at a time. And throughout that process, death may occur. Those are two very different things depending on what you're aiming at. Yeah, we would say, as a denomination, that you should never choose death. Choosing not to endure things is not the same as choosing death. What other questions do you guys have at this point? Step 3 is choosing a level of flexibility for your decision maker. What is okay for your decision maker to change and what is not okay for them to change? And this relates to some of our conversation earlier. It's really hard to predict everything. You're going to be making these kind of decisions before you're actually in this scenario. And there are new situations that come up. There's new treatments that come up. So you may not be able to predict what things are actually going to look like. So how much flexibility do you want your decision maker to have? Some people allow their decision maker total flexibility. That's about where I am right now. My surrogate decision maker would be my wife. I'd be willing to go through a lot of things, and I can't predict what might happen. She and I have had many conversations. I'm pretty comfortable with her choosing just about anything because I know how well she knows me and I know what conversations we've had. You might also say my surrogate decision maker is my nephew who I see once a year, and I trust him. There's also some things that are a pretty hard line in the sand for me. And I don't want him to have that much flexibility beyond what I've written down, beyond what I've said. Kind of follow the letter of the law. You can determine how much flexibility you want someone to have for you. So some allow total flexibility, some limit flexibility. There's some things that you're able to fudge with. There's other things that are a hard line in the sand for me. And then some people choose no flexibility. Do exactly what I wrote down. I don't care if new treatments come up. I don't care what they say. This is where we're at. And tell your decision maker how much flexibility they should have. Say, this is a hard line in the sand for me. If I can't walk the dog, we're done. Or say, I want you to assess what they're saying and what's going on and make a decision that you think I would make if I was able to. That one's a much shorter section. What questions do you guys have about choosing flexibility for a decision maker? Yeah.
I don't have a question, but I'm just going to assume I'm not the only person in this room who has had that responsibility, and it is not a good thing. It's a lot.
It is a lot.
It's a lot. So
Yeah.
I think the next program that you guys give should be for that person. and not necessarily for us who to choose, but how are they going to cope with doing that decision? It's a tough one.
That's
It's
fair.
a tough one.
You know, it's a really tough one. One of my goals with this is, generally speaking, the more conversations that have been had ahead of time with your surrogate decision maker, the more confident they'll be in what you would and wouldn't want. And it's really difficult at the end of life when you're dealing with a family, you're dealing with decision makers, and they say, we're not really sure what Dad wanted. He always said he'd like to live as long as possible. What does that mean? And then you get a lot of internal strife. So the more you can kind of parse these things out ahead of time, the more beneficial it can be for people.
I have a question about
Yeah.
that. When you become the decision maker and you have others that are in the room that do not understand your responsibility as decision makers who feel they have the right to make the decision, how do you back them off? How do you get the medical staff involved to remove them from the room so that you can properly make the decisions that are made?
It's called security.
Yeah, we're getting into some messiness. As long as it has been well defined. Yeah, so the question was, if you're the decision maker and everyone else wants to be the decision maker, how do you approach that? Hopefully that's been well defined. Ideally it's been written down somewhere, or it's been well communicated with the medical staff ahead of time. Then if we're in a very heated discussion in a room and you're the decision maker, I'm going to remind the room that you're the decision maker. If people have to leave, then people will have to leave.
I can say that support wasn't there when my husband was at the end of his life in Mayo.
Okay.
That's why I'm asking.
Well, that's very unfortunate. Yeah. If it's been well defined ahead of time who a decision maker is.
It was, the advanced directives were on file.
Yeah. Yeah. I'm sorry.
And I, as his wife, was not respected.
Yeah.
I just wanted to bring up there's ambiguity in sometimes a disease process, how fast it'll progress. You may tell someone this is typical, but it's a wide variation. And so the flexibility can be not just for the decision maker, it can be the physicians that come to you, and not all physicians will always give you the same answer.
Yeah. Yeah. Our crystal balls have been broken for a very long time. We're unable to predict things, and there's a lot of variability. You can be caring for two people who have a very similar disease process, and they can have dramatically different courses. And we can't, I was going to say we can't always predict that. We can almost never predict that. Yeah. Yes?
I have a quick story. My husband and I divorced when my son was 3. And so now his father had ALS. My son is now 36 years old, and his father's in a nursing home. The nursing home calls him and says, he's choking, he's on the floor, do I call the ambulance? Well, my son jumps in the car, gets there, takes him 15 minutes to get there, and gets there before the ambulance resuscitates him. And so his dad turned around and got mad at him because he says, I wanted to die and you saved me. Then I get a call from a distraught son at 36 crying because he's like, why did I do that? And he's feeling bad. So some of the things you might want to have beforehand to talk to him when you're sane is, I might say things at the end that I might not really mean, because all I could say to him, it wasn't your dad's time. If it was, he would have died. And got him through that way. So sometimes you got to talk to him before you get to that end, just like you're saying, so that you don't have this person making a decision who is now totally sad.
Yeah.
Following up on that, I've been with families where they do have those tough decisions to make. And I would usually encourage them to make the most loving decision that they think their loved one would want. Mm-hmm. Realizing they may make a mistake. But if they choose to be aggressive, it was the Lord's will that they're going to die, they're going to die anyway. If they choose not to be aggressive, but it was the Lord's will that they die, they will die. Do the best they can, live in God's hands.
Yeah. Yeah, as much as we like to pretend that we are in control, we are not, and we are each going to die. Okay. Step 4 is to tell others about your wishes. This one is reasonably straightforward. Considerations of people you should talk to are your decision maker, your medical providers, your family and friends. That way, hopefully, everyone knows this person is my decision maker. Tell them what you would want, what you would not want, things that you've thought about, people you've talked to. Depending on circumstances, you can also choose to limit who is involved in your medical care. My cousin in Chicago is crazy. I don't want them in the room. You can say that if you want to. No particular dig on Chicago. Talk to other people. It's no use if you sit here and after this you think about things you wouldn't want, and you decide who you would want to be your decision maker, and you don't tell anyone anything. Then we actually haven't accomplished anything. So talk to other people. Yeah.
I updated my directive, and I think it's real easy to keep on going along and forget to do that.
Mm-hmm. Yeah. Yeah, if you have a directive on file at a hospital here and the last time you looked at it was a decade ago, you might want to look at that. Is the person you said you wanted to make decisions for you still the person you want to make decisions for you? Is the phone number correct? Did you actually say the things then that you would want now? Yeah. You had something?
And just a thought that occurred to me is that 2 of my 3 siblings have made copies of their advanced directives and shared it. We've shared them with each other, so
yes.
At least 3 of us out of the 4 know what we want. And that, I guess I didn't really think of that before, but I think that is important.
No, that's really important, and that also ties back to the question earlier of, if I'm out of state and no one knows me from Adam, how are we making decisions? If you come in and you're able to provide us with, these are the written down things with these signatures dated at this time of what this person would and wouldn't want, and I'm the decision maker, that can help provide a lot of clarity. Yeah.
I don't want to jump ahead, but if I know who I want to be my decision maker, where do I store that information? Is that something I can give to Mayo and they'll have it forever?
Yeah, so most hospitals have a way that you're able to send them an official document. Like, I can speak specifically to Mayo's system, but there's an easy spot where I can click to see anything you filed related to this advanced care planning. If you're someone who snowbirds in Arizona or in Florida or Texas or wherever, you can send that to those hospitals as well. You could also think about sending it to multiple hospitals if you're likely to be taken by an ambulance to a hospital that you don't frequent. So putting it on file is a great idea. Also, making copies and giving it to loved ones or giving to your decision makers is really good. If nothing else, putting it on file with wherever your primary care is received.
How do we get it on file with Mayo?
The logistics of that.
There's a booklet that you can get
Yeah.
on any unit, and for advanced directives, you fill it out, then you give it back to your provider, and then they put it into your chart, scanned into your chart.
Yeah, if you mail it to their office and say upload this into my chart, they should be able to do that. Yeah.
So I work at Northeast Clinic, and so if that's your primary care, please bring it back to them. We've had patients that go, oh, I'm going to Mayo or Uganda for something, and then they have to redo it again because it gets lost. You need to take it to your primary care. Mayo is a big hospital. You need to go to your primary care.
Yeah, primary care is the best answer. Yeah.
I work in billing. You can fax it in.
Yeah.
507-284-0688.
Hospitals really push for it now.
They do. Connie said hospitals really push for it, and they do.
I mean,
For
if
any
you're admitted
procedure?
to the hospital, where's your directive? About the first question they ask you.
Yeah, we ask it pretty early on.
Yep.
Yeah. Yes.
Can I just comment, even
Yeah.
if you have a directive, if you're capable, I'm still gonna ask you, what do you want?
Yes. Yeah, absolutely. Yeah. Yeah, thank you. Even if you have a directive, is what he said, I'm still going to ask you, what do you want? And that's very accurate. Because if you have the mental facilities to still make decisions for yourself, you're able to disagree with your past self. Yeah.
So what if we're traveling on there and no particular destination? Are we supposed to be carrying our directives with us in case something happens? I mean, that sounds kind of...
Some people do.
Some people do.
Yeah, some people do. Yeah, that's up to you. But you could consider that, especially if you have some extra things going on, some extra complexity. Okay. The last step, and then I think we'll have a little bit of time for some open questions, is to ask medical providers the right questions to try to foresee things. As you're talking about different treatments, different surgeries, different things you might go through, ask specifically about risks, benefits, alternatives. These are things that should be brought up to you, but it can also be helpful to ask specifically about them. If you have a bum knee and you're looking for a surgery, and they're proposing a surgery, what are the risks of that surgery? What do they expect the benefits to be? What are the alternatives? And do you actually want to, what do you think about the risk-benefit of going through a particular thing versus the alternatives that are available to you? Ask about a treatment course and outcomes. What will life be like after treatment? If this goes perfectly, best case scenario, what will my life look like? Granted that we're far from perfect and can't actually predict this. We can give an idea of things that we've seen. What's the best case scenario with this treatment? What's the most likely, or what's the worst case scenario? If the best case scenario with a treatment isn't something you would want to experience, then we've probably found a pretty clear line in the sand. If the best case scenario is something that you're open to but is really unlikely, and the most likely scenario is something that you would never want to go through, then maybe that's not something that you want to experience. So ask about risks, benefits, and alternatives. Ask about what life will be like after treatments, and about things like best case scenarios and worst case scenarios. Before a visit, consider writing down questions that you're hoping to ask, and bring someone with you, because 2 sets of ears is always better than 1 set of ears. to actually know what has been communicated. During the visit, say, preferably at the beginning of the visit, that you have questions that you want to make sure that we discuss. If I have 30 minutes with you, and we spent 25 minutes talking about your inhalers, and it turns out you had a list of 20 questions you wanted to talk about, it's helpful if you tell me that at the beginning of the appointment, because then I can triage that time differently, and we can actually do what's more important for you. Don't save that until the hand's on the doorknob. And reword things to make sure that you understand. This can feel really artificial, but that'll let us assess how much are you grasping what's going on. And it's also a really fast way to clear up any misunderstandings. What I heard you say is that I'm going to get surgery, I'm going to leave the same day, and it's guaranteed I'll be walking in a week. No, that's not what I said. Let's reframe. Okay, so summary. We discussed the definitions of some important terms. We went through 5 steps to prepare for your care. I keep using that phrase because that's a website that's really helpful. I have no particular affiliation with them. Step 1 is to choose a medical decision maker. Step 2 was to decide what matters most in life. Step 3 was to choose a level of flexibility for your decision maker. Step 4 was to tell other people about your wishes. And step 5 was to ask the right questions. This is that website, Prepare for Your Care. This is really hard to read, but there's things built in right on here with video examples. You can click here to do your own medical decision making. If someone is helping you with this, or if you're helping someone else with this, there's this one here if you're helping someone else with their medical plan and decision making. And it walks you through steps, and if you answer the prompts along the way, at the end it spits out a bunch of files that you can print off, and that's your advanced directive. It also answers a lot of questions related to things we've talked about today in a much deeper format. Some LCMS text on this topic, if you're particularly interested, especially as it relates to things like, is choosing to be comfortable the same as choosing death? These are 2 helpful documents. The first one is Mercy at Life's End, a guide for laity and their pastors. And this one is Christian Decision Making and the End of Life. This was an update in 2023 to some prior LCMS texts. Things I said today, in general, have been aligned with what these have said. They go a little bit more into some of the theological aspects and some of the ethics behind some of this, if you are someone who likes to read things like that. Okay, now we have, thankfully, a little bit of time for general questions.
Can you get some of those brochures?
For preparing?
those.
Yeah, we can copy some off. Yeah. Try to
Yeah.
get some.
Just a quick question, the directives to give to Mayo or whoever your doctor is that a legal document? Does it have to be notarized? Does it require any legal intervention at all?
That one in particular, I wish Justin was still here because he could answer some extra specific.
The notary's at
But-
Northeast, so I don't know, you'd have to call your own clinic, but we have, the medical secretaries are notary.
But it
No.
does have to be notarized?
Yeah,
You
yeah.
can make it
Do it
legal?
there.
Okay,
No.
that's,
It's a
Okay.
green 8.5 by 11 book.
yeah,
I'm sure many of you've seen it.
right.
It has to have witnesses, 2 witnesses.
Yeah.
Yeah.
Your physician cannot be a witness.
Yes.
And the nursing staff.
Got it.
Right,
Yeah.
Thank you.
medical secretary.
Thanks.
For the healthcare directive in particular, and that's the one that
Talk a little louder.
So for the healthcare directive, which is one of the options, and that's the one that I do, you have the option technically, but we have had it come back from different doctors saying, hey, you forgot to have 2 witnesses, or you forgot to have notary. So we tend to do both, but so it's a very straightforward document.
Okay, thanks.
Yeah.
I do have a question. How do you encourage people to actually get these done so that, because we have a large family and it'd just be nice to have it down. Dad has Parkinson's. His choices are not going to be what mom's choices are going to be. They're at 2 different paths at the end of life. How do we encourage them to actually sit down, take the time, and get it completed?
Every time you go for a medical appointment anymore, for the most part, you will be asked, do you have advanced directive? They'll ask you that even at the front desk before you get into your provider. So it's just asking people over and over.
if you're
And-
there, they actually can go over the thing with you and help you.
Could also take copies for your parents. Ask for copies.
Done that. I started my dad's, and he got to a point where he was exhausted, didn't finish. My mom keeps saying she'll do it, but hers is sat on the grinder now forever, and I think it's been lost. But we need them. My parents are in their 80s. They're not going to live forever. I don't want to be trying to make those choices, and I don't think my siblings do either.
There's a lot of complexity there, because it's your family, and you know them best. I think I would consider telling them what you just told us, of we're going to have to make decisions for you, and I don't know what you want, and I need to.
The most persuasive argument I've usually had is telling them this will keep us from fighting as your kids.
Yeah.
That seems a lot of parents will respond to that.
Yeah, if you don't want us to be arguing at the end of your life, this is a way to help avoid that. Yeah. Yeah.
I don't know how to word this, but I know a man that doesn't want aggressive, but his wife does. And she's the caregiver. She's designated. And it's the reverse. You know, it seems to me that the wife is having more difficulty than the man.
Yeah.
Any help for that?
That's another messy one, and that's where I'll reference that everyone's quality of life is different. My answer to that will exist on a spectrum depending on how strongly he feels and how strongly she feels. One uncomfortable thing that we will encounter sometimes is patients who don't really want much and family members who do. And sometimes it's clear that this is the line in the sand, this is where we're going. Other times I've dealt with patients who tell me, I really don't want to go through this treatment, but it's really important for my spouse that I do. And for some people, the most important thing when they pass is going to be their loved one's comfort with how that happened. So I have seen people choose to go through uncomfortable things that of themselves they wouldn't necessarily want to do, but for one reason or another, they think this is what my loved ones want me to experience for them to be comfortable with my death. That can be extra messy, though. There's a lot of gray in these conversations.
But isn't that why we get it written down in an advance directive? Because then it's their words saying, this is how I want my care to go.
Yeah. Yeah, if those kind of situations I'm referencing have been when people are still able to make their own decisions. And they'll tell me I'm doing something that I actually don't really want to do, but I still want to do it because my spouse wants me to do it or because my kids want me to do it. Yeah. Yes?
I'll ask the doctors in the room if this is fair. Sometimes people are struggling with the decision either for their own treatment or the treatment of a loved one, and they really don't know what to do. And I'd encourage them to ask your doctor, if it were you or if it were your mother, what would you do? Is that fair?
I think it's a fair question. There'll be different answers from each person you ask, because my usual first response is going to be, I'm not you and I'm not your mother.
But what I've found sometimes is the doctors can sometimes say what they would do. It's not saying what you should do,
Yeah.
but it gives a perspective, because oftentimes the doctor will be biased saying, we've got to do this, we can do this, we can do that. And maybe they're not thinking they should do it, but they've got to say we can do it.
Yeah. Yeah. No, I think it's a very fair question. Sometimes we'll be hesitant to answer it.
Yeah. Fair enough, yeah.
Yeah, I don't know, anything.
It's like, uh-oh, another 30 minutes of my time.
That's the real internal dialogue.
Because you can't answer it without really exploring.
Yeah. I don't know. I'm going to loop in Tori in the back, because if we look at studies of who you trust most, you trust Tori, who's an ICU nurse, a lot more than you actually trust me. I'm guessing family members ask you guys frequently in the room, what would you do?
Providers more.
Okay.
But not every physician, again, directs that sort of answer in the same way.
I think for me, it was helpful when they took X-rays of the lungs and said there was no hope and that type of thing. And I think if they explain things to you, if you're in the state of mind to hear it, I think that really helps a lot with your decisions.
Yeah. Okay.
Any other last minute questions?
Could I just get the slide from the last one?
This one?
Thank you. Yeah, thank you.
Yeah.
I'm going to do what you said. I'm going to restate what I thought you heard say.
Nice.
Okay. Which is the medical directive takes place when I'm no longer capable of making my own decisions.
Yep.
Correct?
Correct.
Okay.
Yeah.
It actually guides your decision maker who will make that decision.
Yeah.
What if you have an issue and you have a medical directive, do not resuscitate or whatever, and the doctor says that's your illness is so minor, we can revive you. Does the doctor overrule your decision?
No. No.
If I can back up on that question, I think they also just want you to understand that I think a lot of people will hear a diagnosis and not fully understand what that means. So I think following up that statement with these would still be my wishes, even if I do survive, I do not want to be resuscitated. I think that's important. Because again, that's just trying to the dialogue of going back and forth to make sure you understand what they're saying as well.
Yeah, if I say you have skin cancer and you say I don't want to be resuscitated, I'm probably going to ask more questions and say that's not really where I think this is going.
Just one added comment. It's so important to be your own advocate as much as the care providers care about you. To ask like those questions of help me understand, or this is what I hear you saying, could you repeat it again? That's okay, and I think physicians appreciate that when they see that you have a real vested interest and you really want to understand. So or write your questions down so you don't forget them as you got them. That's your right, and you're your own advocate. So this was wonderful.
Thank you.